It's for these dysrhythmias, okay? First of all, again, atrial fibrillation. Remember how I said how important it is with rate control, okay? If your patient is compromised, okay, we're talking, BP less than 90, 95 systolic, cold, clammy, obvious signs that perfusion is going in the toilet. You will then cardiovert. And that's for atrial fib and atrial flutter. And that, again, if that patient's perfusion is going in the toilet. So you cannot just look at a rhythm. Okay, so usually what happens, these are at high rates, and your patient cannot tolerate it. Okay, cardiovert. Cardiovert is where you're going to synchronize the defibrillator. You're going to synchronize that. Very, very important to hit the sync button. So what you're doing is the machine will target those R waves. And cardioversion is with lower joules, 50 to 100 joules. Now, if I put and tried to cardiovert you with 50 or 100 joules, you would go, and that, it hurts. So, if at all possible, please give your patient some sedation. That's just cruel. And unfortunately, there have been times when, I'm going to lose that patient. And it is horrible to have to send joules through somebody and not sedate them. But you know what? If you're going to die, you're going to die. I can't help it. But if you can, they do a lot of cardioversion out on the floors. And you want to always try and sedate your patient if you can. This is also a situation where you need the crash cart right there, because you can certainly make the situation worse. Okay, so that crash cart needs to be right there in case something were to happen. Okay? If your patient is not symptomatic, but let's say their vital signs are stable, but they're complaining of this fluttery feeling, I don't like it. Slow the rate. Okay? Cardizem, IV. Beautiful. Okay, cardizem IV. We give them a bolus, and we start a drip. Other things that can be used are, of course, beta blockers. But usually we try to stick with the cardizem. Cardizem IV. Why? Because we can start a drip. It's just easier, and it works great with slowing the rate. Okay? This, again, the same. This rhythm, again, is just easier to cardiovert than this one. Okay? And beta blockers. Sinus bradycardia, symptomatic, BP less than 95-90, systolic, cold, clammy, confused. Okay, we've got some little mentation issues going on here because the blood flow is obviously not getting there. So we're going to go with atropine. Okay, Atropine's a cholinergic. It's going to cause the heart rate to rise. And you're going to give that IV push. Hopefully this is going to buy you some time to then pursue temporary pacer, right? Okay, atropine, IV push. Symptomatic. So symptomatic bradycardia. Okay, high rate sinus tachycardia. Okay, again, it depends on the symptoms. Okay, for this patient. If this is a narrow QRS, and we determine the rhythm to be supraventricular tachycardia, we will give adenosine. Adenosine, again, will block the conduction system. Okay, you can give that twice, 6 milligrams IV push over 3 seconds. And then you can give another 6 milligrams IV push over 3 seconds. And you want asystole. Okay, you want a pause. Because that means the med's in, you're trying to reset. Hopefully, they'll come back to the sinus rhythm. Okay? Now, many a times, when they're in high rate AFib, and they don't know, everybody's sitting there going, it's SVT, it's AFib, it's SVT, it's AFib, it's SVT, it's AFib. They'll give adenosine, but it ain't going to convert. They'll just stop it, and they'll go right back into the fib. Okay? So that's where you're going to see adenosine. In particular, with your narrow QRS, SVT, high rate tachycardia complex. Okay? If they're symptomatic, again, you can give cortisone. Oftentimes, they'll give beta blockers. Okay. And I'm not going into sinus tachycardia Y complex, okay? You guys, if you want to get the down and dirty, take ACLS. Okay, that's advanced cardiac arrest. Okay, remember with your VTAC. If you have VTAC with a pulse, you're going to cardiovert. A VTAC with a pulse is cardioversion. Because they're not going to have that pulse long. Anytime you have pulseless VTAC, you want to defibrillate. If they remain in VTAC, you want epinephrine. Everybody should know that's a catecholamine. Epinephrine. Okay, IV push. That can be given like every 3 minutes. And if they still remain in VTAC, your next drug is amiodarone. Or Oradone. Amiodarone has now replaced lidocaine in many, many situations. And what do? That applies to pulseless VTAC and, of course, the pulseless VFib. Defibrillate. If they remain in that, you're going to be given epi every 3 minutes, and you're going to rotate, you're going to alter that with amiodarone. Epi, amiodarone. Epi, amiodarone. You want to learn the max doses and all the other stuff that goes along with this, ACLS. Okay? So, again, what is very, very important to remember about cardioversion? Synchronize crash cart. It's low joules. When you hit the sync button, it's going to be low joules. What else?
The date before.
What else did I tell you? Sedate the patient if possible. Okay, Ms. Hyde was telling me about a patient that she had that taken care of, and they came to cardiovert this patient. It was an older woman, and they did not sedate her when they could have. And so she's laying there on the bed, and she tells the whoever came to do the cardioversion, she said, "Come here, come here, come here." She slapped the man, okay, because she said, "That hurt." You know, you just put joules through my myocardium. Yeah, she slapped. So, very different than when you're pulseless, you know? We don't worry about cracking ribs, we don't worry about it, because you're dead. So, and defibrillation is now, well, the joules are actually a little bit lower now with the different types of defibrillators they have out there. But anyway, you want to defibrillate with pulseless, okay? Cardizem for rate, very, very nice one for rate, okay? And your betas, a lot of betas you can give IV push. Okay, labetalol is one. Remember, betas are what? Olol, y'all recognize that? Olol, okay? So those are your Olols, several you can give IV. Atropine for symptomatic bradycardia. Very key word, symptomatic. If they're not symptomatic, we're going to watch, right? Because that bradycardia could turn into a block. You don't know. With your high rates, narrow QRS complex SVT adenosine. You give it very, very fast. You want to see the straight line for a few seconds. That's the response you're looking for. This is pretty self-explanatory there. Detach, defibrillate. Okay, they're still in it. Epinephrine, amiodarone. That's for pulses detach defib. Okay. Okay. So let me pull up. Just so you guys know. I can assure you these are ones that happened to me. Nothing like, a big giant male falling to the floor and little me. So, again, I assess for pulse, they're pulseless, I call a code. Okay, because God knows I need help. I'm manly. Again, looking for that symptomatic clinical manifestations. So again, if this patient is pulseless, what do I need to do? Call a code, and what do I need?
Crash cart.
Yes, you need that defibrillator. If you're in a code situation, we usually have certain responsibilities for a code. There's usually someone managing the defibrillator, someone CPR, someone, of course, respiratory at the breathing, bagging, intubating, whatever. Someone documenting, for heaven's sakes, and then someone managing the medications, okay? Your role as a student, really, you guys want to be performing CPR. If you've never performed CPR on someone that is coding, it's just a really unique, I shouldn't say unique, doesn't that sound awful? But I mean, there's nothing like an excited student going, I can feel the I mean, it's just, we are so weird. I mean, it's just, so you do have stations. Hopefully you got a physician who has a clue. It's always good. When we get to MI, you guys are going to have a job for a long time, okay? We are nowhere near our 20 goals. Again, you want to prevent that myocardial infarct. Plain English, you want to prevent necrosis, okay? Because that cannot be reversed, okay? Remember now, according, you guys know your guidelines, it's compressions. This is just legal stuff. You can read that, no big deal. Well, I should point this out. I know, after I started looking at it, I thought, no, I need to point this out because somebody may not realize this. This simply means you're not going to perform life-saving measures. Okay, that does not mean you are not going to treat that patient. Okay, a lot of my first-year students were like, well, they're a DNR. What are they doing on the monitor? Like, really? Because they're not dead. That's why. They just don't want somebody pumping on their chest. Okay, so if you are taking a DNR to RNs, okay, so if that's where we're going with this, I tell somebody to get online, okay, we're going to be a DNR. A DNR, again, is valid for that hospital mission. And you'll be surprised somebody decides they no longer want to be a DNR. Okay. In this state, you will see alterations. It's kind of sad to me. We're not going to pump on their chest, but we're going to give them drugs. I mean, how much sense does that make? I mean, literally, you'll see that. Don't intubate, even though you're not getting any oxygen. But who knows? Okay, the golden rod, again, when these patients come from that nursing home, they need to have that little piece of paper right there coming in with them. That's the last thing you ever want to see is, little old grandma who has made her wishes very known, and they can't find the dang golden rod, okay? You're like, really? I've been in a lot of situations, guys, you're not going to believe it, especially if you're with me. We see such ethical issues. It's just amazing. This is a new trend in the literature, having family present at the code situation. Actually, the literature has been very positive in that the families actually obtain closure if the patient doesn't survive. They also see how the team does everything within their power to help save this family member's life. So the literature is actually quite positive about having family present. Again, these are your areas. As I mentioned, you guys get in there and do CPR. Sometimes my students, I try to stand on the outside going, watch, there goes that drug, this drug. Some of them like to hear me critique what they're doing. Again, you need somebody with their act together. It can be a lot of commotion. There doesn't need to be 10,000 people in there. Okay? If I arrest, I want the one of you that's thinking at the moment, okay, to be in there to make sure the proper decisions are made. Again, you don't want to see that necrosis to the myocardium. Call code. This is, again, this is not on your test. It is just something for you to know. If you witness pulseless V-tach or V-fib, that is where you'll actually see them. It's called a precordial thump. Sometimes I rarely see it work. The one thing I want to point out about defibrillation is, again, you are sending a large amount of joules to the myocardium, and if you are standing and leaning on that bed, you're going to be shocked too. Okay? Extremely important to say all clear. Dodo had her dang chewing gum. It only took once, you know. One time, okay? Because I'm so short, I usually have to get up on the bed, so I got off, and sure enough, my little knee was not far away. It hurts. I mean, that hurts. So all clear, you know, is wise. I mean, it's wonder and do something to me, you know. I was young. That's when I was young, back in my little pigtail, you know. Okay. The current guidelines are what is now recommended. This is 2010. For those of you who are thinking about ACLS, these guidelines will be in place until 2015. Okay, so they're going to be changing soon. They change them every 5 years. The big change was the compressions. That's obvious. If your patient is symptomatic, you know, put a little O2 on them. Don't sit there and say, I need a doctor's order. I'm like, dumb. You know, put some oxygen on them. If we can't get them out of the rhythm, we will have to intubate. We'll actually talk about intubation that's next week. Because, yes, ventilators could be on your NCLEX. Okay, this is return of spontaneous circulation. That's what that means for those of y'all who are interested. Now, again, don't get into the meds that I mentioned are the ones you want to focus on, okay? Pulseless, remember you're going to defibrillate. I know I keep saying it again, but, you know, it seems to help. So, it's pulseless, you're going to defibrillate, epinephrine, amiodarone. Don't even look at some of these others unless you're just like, you know, yes, I want to look at this. Okay, remember, bradycardia, atropine. You want atropine. No, I'm not testing you on dosages. Okay, you take ACLS, they will test you on dosages. You guys are looking solely at the meds for the specific rhythm. Okay, atropine. Don't go there. Okay. Well, that's obvious to me. You know, if you're true asystole, you can't defibrillate it. So you're going to give the most potent catecholamine. Okay. Don't go there. This is the one about your AFib, A-flutter. Remember, here's your cardizem and your beta blocker, okay? So don't, if I didn't mention it, I mentioned cardioversion, then just, if you want to, skip it. Some nice strips, too, that you can review. I did mention your supraventricular tachycardia and adenosine. I mentioned this one, cardioversion. Certainly, you don't need to look at. I did write it out, didn't I? Okay. Just the ones I mentioned. Okay. This is, the only reason I put this in, this is FYI, this is some of that evidence-based practice. We are now, if you arrest out, maybe in the ED or out in the field, and they get you back as far as perfusion from a rhythm standpoint, but you are not waking up, then those are pretty much the big candidates for our hypothermia protocol. We've actually had some good success with that. We actually bring them in, and we're going to cool them down to 94 degrees Fahrenheit. So, you know, these babies are, they're pretty cold, anywhere from 90 to 94 degrees Fahrenheit. So we cool them down. That's a very slow process, and we rewarm them, buying them time and hoping that they'll wake up and will have normal cognitive function. And we've had some great success with our hypothermia protocols. So just FYI to let you know. So that's something that's still out in the literature. So again, that is where you'll find those meds. It's got some good strips you can review as well, okay? So, now